I thank Dr. Deepak Gupta for giving me this opportunity to pay tribute to two very important Scottish neurosurgeons. I'm also grateful to Dr. Ketan Desai for his kind and courteous introductory remarks. Dr. Ramkrishna Kamath of the St. G.S. Medical College has helped me to make this recording, and I'm very grateful to him for his help. The first slide shows Dr. Brian Jennett. As you can see, Dr. Brian Jennett was honored by being nominated Commander of the British Empire. During his neurosurgical training, he had the opportunity of working with Sir Hugh Keynes and Dr. Pennebaker. But the part of his training that concerns us today is the work which he did in America with Dr. Horace Magoon. And as you know, Dr. Magoon was working on the reticular formation. And perhaps it is this training and the work that he did in Dr. Magoon's laboratory which inspired Dr. Jennett to continue working on consciousness and then the loss of consciousness after damage to the deep cerebrum and the brainstem, and develop the concept of brain death and the implications of this concept as far as organ transplant is concerned. I've listed some of his books, and you can note that all three of these have some relationship to brain injury, the vegetative state, legal dilemmas, and the ethical aspects of the diagnosis and of brain death and organ transplantation. The second Scottish neurosurgeon that we are honoring today is Sir Graham Teasdale. And Sir Graham Teasdale has been nominated as the Knight Bachelor by the Queen. His mentor was Dr. Brian Jennett. And Dr. Teasdale's eminence can be noted by the fact that he's the president of such important societies as the Society of British Neurological Surgeons and the Royal College in Glasgow. The key papers that concern us over here today are the papers which describe the coma scale which he devised in cooperation with Dr. Brian Jennett. And it is this scale that we now know as the Glasgow coma scale. I must caution you that this talk has nothing to do whatsoever with these three elements. There is a music band which is called the Glasgow coma scale. There is an Australian footballer whose name Graham Teasdale. And there is a well-known taxidermist in Great Britain who is called Graham Teasdale. And this talk has nothing to do with either of these three entities. What this talk is going to deal with is brain death, the history of the concept, and the implications of this concept for organ transplantation. And these are some of the key papers by these two Scottish surgeons whom we are honoring today. Dr. Brian Jennett, in collaboration with Fred Plum in 1972, wrote about the persistent vegetative state. Then Graham Teasdale and Brian Jennett described the scale that they had devised for the assessment of coma. In 1975, Dr. Brian Jennett prepared a key paper on observations on the recognition and management of brain death. And in 1977, that means 2 years later, he wrote about the ethical aspects of the diagnosis of brain death. If we trace the history of the diagnosis of death, as all of us know very well, the first, starting from the days of Hippocrates and Charak and Sushruta, death was diagnosed by the fact that the patient stopped breathing and remained devoid of any breathing whatsoever. There was a permanent stoppage of breathing. And this is very well brought out by Shakespeare in his play King Lear. where King Lear, holding Cordelia, his beloved Cordelia in his arms, he says, I know when one is dead and I know when one is alive. And she is dead. And as if to prove his statement, he says, lend me a looking glass. And if her breath will produce a mist on the looking glass, why then she lives. So he knew that if the person is breathing, then he is not dead. But if the person is not breathing and you hold the looking glass in front of the nose and the mouth of the individual, that glass will not show any mist, water vapor condensing on that mirror or glass. Then came William Harvey, and he published that remarkable book on the motion of the heart and blood. And from that time onwards, the diagnosis of death rested on two pillars. One was the permanent stoppage of breathing, and the second was the permanent stoppage of the action of the heart, which peripherally we recognize by the fact that there is no pulse. And there is no pulse no matter how long we continue to observe. One little historic tidbit: asphyxia in the 18th century referred to stopping of the pulse and had nothing to do whatsoever with breathing. And I've given you the Greek derivatives, which made this meaning obvious to the 18th century physicians. Of late, we find that the criteria for the diagnosis of death need change. And why have we decided that this change is necessary? The use of the ventilator, of drugs, the care of the lungs, cardiac resuscitation, and vasopressors, all these disallow the use of breathing and the heartbeat as indicators of life. As long as you continue the ventilator, there will be some respiration. And as long as you continue cardiac resuscitation and vasopressor, even though the patient is dead, the heart will continue to beat for some time, which may be minutes or hours or even days. So the patient is dead, but the heart continues to beat. So these two facts made it necessary for us to change those pillars on which the diagnosis of death had rested so far. There are some other factors which make it necessary for us to change the method by which we diagnose death. We know now that permanent irreparable damage to the deep cerebrum and the brain stem carry a hopeless prognosis. No matter what treatment you give and no matter how long you continue the treatment, the patient is not going to return to consciousness and life. Now, if this is so, and we know that this is so by experience and by experience all over the world, then the costs of treatment of such an individual in the intensive care unit, these costs are totally waste. They are wasted because no matter how long you continue treatment, the patient is not going to recover, and eventually, in minutes or hours or days, the heart will stop. So, if we are going to incur this kind of treatment, costs of treatment on a person who is dead, we are putting the family to an expenditure, horrendous expenditure, which is not justified. Secondly, as long as such an individual remains on the intensive care bed, that bed is not available to those persons who have injuries or illnesses which can be salvaged. The patient will improve and will walk out of the hospital. And that patient cannot be admitted as long as this bed is occupied by the brain dead patient. And finally, continuing to treat a dead person is only prolonging the agony of the events to relatives and to friends. So this is why it was important to change the criteria by which we make a diagnosis of death. Now, how did the concept of brain death develop? Mark the year 1959, and these two French physicians, Mollaret and Guyon, described what they call coma dépassé. Now, coma dépassé, translated into English, means irreversible coma, or what we today understand as brain death. And they described 23 patients in 1959 with total and definitive abolition of vegetative functions of the brain. They also went ahead and suggested that there was a need for a new means of assessing the frontier between life and death, because other organs may take hours or days before they cease to function. And they said this with particular reference to the heart. This was 1959. Now, it took 9 years for this to be taken up for discussion, debate, and investigation by the ad hoc committee of the Harvard Medical Bulletin. This ad hoc committee was set up to examine the definition of brain death. And after a lot of discussion, in 1968, they made these 4 criteria. Number 1, the individual should not be able to receive any impulses. And the individual should not be able to respond, no matter what the stimuli. So unawareness or lack of awareness of external stimuli and lack of response to pain, no matter how severe the pain is. The second criterion was that there is no movement of any part of the body, spontaneous or even induced by pain. And secondly, that there is no breathing whatsoever. You can go on waiting for minutes and hours, but there will be no breathing. There are no reflexes. The pupils are fixed and dilated. There are no eye movements. And if you inject ice water into the external canal, there is no response whatsoever. But the fourth criterion that they introduced caused a certain amount of debate. They felt that a flat electroencephalogram was a necessity to make a diagnosis of brain death. So in 1972, a new task force was set up, and the proceedings of this task force were reported in JAMA in 1972. This task force had consulted several clinical neurologists, and they concluded that the clinical and the more comprehensive criteria of the Harvard report should be adopted. But EEG determination was not necessary for determination of death. So it was not necessary to have an EEG to make a diagnosis of death. In 1975 came that epoch-making paper, which I described earlier, the paper by Dr. Brian Jeanette. And this is the first time that the term brain death was used. He actually coined this term brain death. And he focused essentially on the brain stem. The Harvard committee had focused on the entire brain, which is why they insisted on an EEG. But when Dr. Brian Jeanette studied the whole situation, and when he drew his conclusions, he said the focus must be on the brain stem. Because when the brain stem is permanently and irrevocably damaged, the patient dies. So we should focus on the brain stem when defining the criteria for the diagnosis of brain death. He made a very pointed statement: EEG recordings and cerebral angiography are not required. And this was very important because now we could make a diagnosis of brain death at the bedside. We didn't need expensive equipment. We didn't need a radiology department. In this paper, he also discussed sources of error. Where can we make a mistake in the diagnosis of brain death? And in the process, he described or discussed the persistent vegetative state, locked-in syndrome, and peripheral paralysis as likely sources of error. He also showed that spinal reflex movements may persist after death. This is quite an interesting point which he made in 1975, because even today, when we tell the relatives that this patient is dead, in the sense that he's brain dead, they often point to occasional jerky movements that they notice and they say, look, he's moving, how can he be dead? That is because they are unaware of what Dr. Jeanette had pointed out in 1975, that some reflex movements may persist after brain death. And he argued that even after we make a diagnosis of brain death, do not take off the supportive measures. Do not stop the ventilator, do not stop the vasopressors. Continue doing everything possible to keep the other organs alive, because we may be able to use those organs to save lives of other individuals. So he already foresaw the need for keeping all the other organs functioning to the best of our ability in case they were to be used for transplantation. And this, of course, is a slide which all of you are very well aware of, because it shows our current understanding of the biology of brain death. And I particularly call your attention to this black line over here, which is the line which separates the live patient from the dead patient. And if nothing is done, once this line is passed, then the brain is going to liquefy. And all the other organs will become functionless and therefore of no use to anybody. Now, the concept of brain death had been made. How was the concept of organ transplantation developed? And strange though it may appear, in the Western world, it was the Catholic Church and the popes who showed the way. 1956, Pope Pius XII, he made this statement: organ donation should not be condemned, but it should be positively justified. A year later, he was addressing an international conference on anesthetists, and he was asked a question: can a doctor remove the artificial respiration apparatus before the blood circulation has come to a complete stop? Now, this was at a time when organ transplantation had not yet developed. So he said, yes, when death has already occurred after grave trauma to the brain and central breathing paralysis has occurred, then what is the point in keeping this artificial respiration going on when and wait for the blood circulation to come to a complete stop? Doing this is not going to bring the patient back. The patient is already dead. So he was emphasizing the concept of brain death before the heart dies in the year 1957. Now, these are some of the statements that the popes have made on brain death and organ transplantation. Pope Pius XII, 1957, he insisted that the precise and clear definition of death and the moment of death is in the realm of medicine and not in the realm of the priests. Theologians must defer to doctors. It is the doctors who have to give a clear and precise definition of death and of the moment of death, not the priest, but the doctor. John Paul II, 1995, he described organ donation as particularly praiseworthy. Now, please remember that statements made by these popes were of tremendous importance to the Catholic world. they went by the statements made by the popes. And when the popes championed the role of physicians in the diagnosis of death, and when the popes sanctioned organ donation as being praiseworthy, you can be sure that it made it easier for the Catholic population to agree to a request for organ donation. Pope Benedict XVI in 2008 was asked the question, what is the morality of this kind of a donation? And instead of saying anything, he just responded by showing his own card, which showed that he had said that his organs should be used for transplantation after he was dead. There could be no challenging the morality of these kinds of donations once he showed that he himself wanted to be an organ donor. Now, what about brain death and organ transplantation in India? This came into the public domain only in 1994, when the Transplantation of Human Organs Act was passed. And I've given you some details about this act right at the top of the slide. But this act had two deficiencies. Firstly, this act included the definition of brain death in an act which was actually meant for organ transplantation. Brain death should have been separately defined in a completely separate act, which was not done. It was subsumed in the Transplantation of Human Organs Act. Secondly, this act gave no direction on what is to be done about the support measures once brain death was diagnosed. And if the patient was either not fit to be an organ donor, or the family decided they did not want to donate the organs. So what is to be done in that case? The patient is on a ventilator, the patient is on vasopressors and so many drugs and so many infusions. What is to be done about that? The Act provided no direction on this. And this was a tragedy because administrators of hospitals refused to permit their clinicians, in particular the neurophysicians and the neurosurgeons, to discontinue all support measures once brain death was diagnosed, because they did not want to enter into any kind of a medical legal problem. So they would not allow discontinuation of support measures, which means that ventilator, infusions, vasopressors, intensive care treatment, all this had to be continued till the heart stopped beating. Now, this meant a tremendous amount of expense to the family. This also meant that that bed was now not available to anybody till this patient's heart stopped beating. And there's a review article in 2018 about how this Organ Transplant Act in India can be simplified. Now, the present position has been very well discussed in a position paper which has been put out by the American Academy of Neurology in 2019. And I've given the reference to this paper, and this paper is well worth studying. It makes very categorical and unequivocal statements. Brain death is death. In fact, some have gone to the extent of saying we should take out the word brain. We should say these are the new criteria for the diagnosis of death. Because the moment you say it is the criterion for brain death, then people start looking at the ECG tracing and they say, but the heart is beating, how can the patient be dead? And so on and so forth. This paper also pointed out that neuroendocrine function may continue for some time after brain death. It asks for uniformity of the diagnosis of techniques used for the diagnosis of brain death all over the world. Finally, they made a statement which is very, very important. It says where the brain death guidelines have been accurately followed and a diagnosis of brain death has been made, there is not a single person who has been diagnosed as brain dead who has returned to life, who has returned with normal brain function, including consciousness and ventilatory effort. Not a single patient. That means these guidelines for brain death have been well formulated and have been proven by experience. There have been a few disconcerting observations which have created a lot of difficulties and which have also resulted in a lot of questioning of this Academy of Neurology paper. And the most important of these, the most prominent of these is the case of Jahi Mahmat. Now, Jahi Mahmat, who was 13 years old, was admitted for surgery to stop obstructive sleep apnea, 9th December 2013. 3 days later, she suffered a cardiac arrest. After that, when the patient was examined and all the necessary tests were done, a diagnosis of brain death was made and a death certificate was issued. But the family disagreed with the diagnosis. The family was told that, look, no matter what you do, in a few hours or in a few days, or maybe in a week or two, the heart will stop beating and the patient will die. The mother said, no, I don't believe you. I want to take this baby home. So she took that 13-year-old girl home in this condition, kept her on a ventilator, and continued gastric feeds. Now, this became headline news in American newspapers. So naturally, reporters and a whole lot of other people kept on inquiring, and the family kept on saying, she's doing well and she's improving. But when neurophysicians examined the patient, they found that the patient was unresponsive, did not feel any pain, and was unable to breathe if the ventilator was stopped. So the diagnosis of brain death was correct, but the heart had not stopped beating within hours or minutes or days. In fact, the heart stopped beating only on 22nd June 2018, which means almost 5.5 years later, when the patient had hepatic failure and bleeding. And that is when the conventional diagnosis of death could be made. So this kind of a case has produced a lot of questioning about diagnosis of death. Are the criteria for the diagnosis of brain death infallible? Can doctors make a mistake, and so on? And the Scientific American in October 2019 put out this very, very interesting proposition. Is death reversible? That means by our criteria, the patient is dead. But is it possible that we are wrong? Is it possible that the patient can be restored to life? And they referred to an experiment which had recently been carried out on pigs that had been slaughtered. And these researchers took the pig's head and brains, and they studied those head and brains after they had been separated from the rest of the body. And they felt that there was a partial revival of the function of the pig brain. If you keep blood flowing through these brains, if you keep glucose going in, and if you have a venous outflow where what is going in comes out, then there is a partial revival in the functions of these pig brains. Now, you need to study the paper which described this experiment, and that paper, the reference to that paper is provided in the Scientific American paper. So, Scientific American put out 2 or 3 important points. Number one, death has always had a change in definition. Not always, but over the millennia, the criteria used for defining death have changed. And as we have discussed earlier, Originally, it was cessation of breathing. Later, it was cessation of breathing and a heart which has stopped permanently. And then the advent of ventilator shifted the locus of death to the brain. But this question of partial revival of brain function in a pig hours after decapitation, could it upend the definitions of mortality? This is the question that they have asked. So there are certain points which we need to worry about, which we need to think. First, and this is very important practically in India, there is a confusion between cardiac death and brain death. So when you talk to a relative that this patient has died, and you say that we have done the test for brain death and the test show that the patient is dead, they will point to the cardiac monitor, which is by the side of this patient, and say, but look, the cardiac tracing is normal. The heart is beating. How can you say this patient is dead? So they are unable to differentiate between cardiac death and brain death. And it is our responsibility to explain this to them and to provide the information that they need. Number two, brain death is not always followed by rapid disintegration of the rest of the body if ventilation and feed through a gastric tube are continued. And the example I showed you of McGrath is a brilliant, beautiful example, excellent, dramatic example of the truth of this statement. Should such patients then continue to remain on ventilators, and should they continue to be fed through gastric tube? Those who think in rational terms, they say, look, what you are doing is you are not supporting life. You are merely delaying death. The trouble is that there is a single documented case of such an individual surviving, if you call this surviving, in a vegetative, permanent vegetative state with no normal functions and unable to survive if you stop the ventilator. The longest is 20 years. So it has created several problems, and we need to think about these problems and we need to find answers to them. Now, what does the future hold as regards brain death and organ transplantation? And I think all of you must have read the report, which was published in January this year, of a first pig to human heart transplant. This is a genetically modified pig, modified in such a way that most of the genetic criteria match those of human beings. And one such heart had been transplanted in Baltimore, in the University of Maryland, into a human being who would otherwise have died. He needed a heart, otherwise he would have died. So this is the heart on display on the top right-hand corner, and this is the heart that was put into this patient. And immediately after the operation was done, and for some weeks after that, the reports that we had were that the patient was doing well after the procedure. I'm afraid I have not been able to follow up this patient up to today. I don't really know what has happened after that. But transplant surgeons are hoping that this advance will enable them to give more people animal organs. But of course, there are ethical and technical hurdles which have to be crossed. So I'm going to leave you with some thoughts. The first thought is answers to these points, which are labeled here as points to ponder. And the second is about the future. Will animal organs make it unnecessary for us to ever take organs from a brain dead person for transplant? Will this ever be necessary? I leave you with these thoughts.